Thank you so much. Dr. Sultan really knows how to stir up the
Correct,
crowd.
Professor. Yes.
Okay, so I'm going to present a case that goes along with this particular session, and it's a carotid. And I thought I'd get in just before the debate, so maybe I can help a few people who are participating in the debate now, whether it's for the pro or the con, I don't really know. So I'll have Stephanie present this case. Go ahead.
Okay, so this patient is a 73-year-old male. He has a history of coronary artery disease, hypertension, hyperlipidemia, carotid artery stenosis. We have been following him in the clinic for several years, actually. Serial ultrasounds, and he's had a few CT scans in the past. If you want to go to the next slide. So this was his last ultrasound about 6 months ago. You can see he has pretty high velocities in the 300 right at the bulb, and the ratio at the bulb was around 7. We did discuss intervention at that time, though he was asymptomatic and actually patient preferred to continue with medical management. He was on antiplatelet, statin. He was, his preference really was medical management.
So let's stop here because I've been following this patient for quite some time. At this stage, we did offer him, can you get the ultrasound back? At this stage, we did offer him an option of an intervention, whether it be ENDOT or whatever. And at that time, the patient was on Lipitor and cholesterol medications. Now, I don't know whether Dr. Sultan would have stopped it, but he still also was on aspirin and Plavix also. And after much discussion with the patient and the patient's cardiologist, they decided to continue conservative treatment and antiplatelet regimen. Next.
Next slide. So then the patient presented recently with a brief episode of left arm and leg numbness, some mild weakness, and a facial droop. His symptoms resolved within several minutes. He came back, he saw us, and again, we discussed intervention. If you want to go to the next slide, we'll have his more recent ultrasound.
Yeah, and there's been a marked change in that ultrasound too. If you look at the velocities as well as the ratios, the ICCCA ratio is almost 10.2 compared to his left side, which was 0.9. So obviously, an intervention was definitely indicated based on findings and clinical signs and symptoms, of course. He also did get a CAT scan at this stage. Go ahead.
Now watch close on the...
Why is the CAT scan not playing?
The right side. It's very focal.
This happened yesterday. See, it's a very, very tight focal lesion. Go to the coronals, maybe. Go back slowly. To be honest, that CAT scan, was not very impressive, but on this coronal section, you could see that there was a shelf and almost a near cutoff here. So based on all of his symptoms and everything, we said, yes, you will need an intervention. Now, how many would do ENDOT and how many would do TCAR on this patient was the question, obviously. And so let's poll the panel and say how many would do TCAR, how many would do ENDOT on this patient.
Could you show us the arch also? So
arch is
at least we
it's
have
a type 1 arch.
Picture.
It's a type 1 arch.
Yeah, okay, thank you. Who would do CA from the panel or the moderators?
I wouldn't do CEA. I think it's a short focal lesion. If the arch is pretty straightforward, type 1, I think you have a conversation. But my preference is when they're symptomatic, I have a tendency to do more TCAR than CEA. Multitude of reasons. It's quicker. I got to put them into an already busy elective schedule. This lesion is very
you're always
straightforward.
On the golf course. What kind of busy
short.
elective schedule do you have? So anyway, we debated this.
I'll do CA. It's straightforward CA.
So we debated this with the patient. And
you did mention cervical immobility, Venki. Cervical immobility was in your history.
And we've done CEAs on, even a little bit of cervical immobility and everything. So, but anyway, ultimately we left it up to the patient saying, I would prefer to do a TCAR, and the patient himself wanted a TCAR. And so he discussed it with his doctors, and finally we brought him in and decided to go ahead with the TCAR. So the first thing, of course, with TCAR is you make a small incision between the two heads.
Now, Venki,
yes.
we might actually do Performance 3 because we're part of the trial.
Yes, I know.
So that would be the only other thing.
So I know Sartre is going to be taken to task now because I'm part of the Performance 3 too. And to be very honest, for full disclosure, it's a research study, ongoing study, and we'll talk about it during this case too. And so I don't think I could have done live cases in a research study. So I would have to get IRB approval, Dr. Sacher's approval, blah, blah, blah. So of course, TCAR, yes. And we can talk about the the merits of the current TCAR procedure versus the new TCAR procedure via the Performance 3 study. And also the Contigo system is approved now by the FDA for transfemoral stenting too. Now, it's been a long time since I've done transfemoral stenting, and I've been of the opinion that the arch is the biggest culprit, and the TCAR is like a 30-minute procedure. For Frank, it's about an hour. For me, it's about 28 minutes. And so we decided to do TCAR, a small incision between the two heads of the sternocleidomastoid. Takes about 3 to 4 minutes to expose. You put in a 6-0 Prolene pro-string suture. You puncture the groin. You can go to the groin if you don't mind. Puncture the femoral vein, and then you establish reversal of flow. And that's the whole principle of reversal of flow and the TCAR procedure. And then I did an angiogram after reversal of flow and everything. And here is the angiogram. Can you play that picture, please? Okay. And for a minute, I am like, whoa, will I ever even get into that internal? Freeze it. You see, it's almost like a complete cutoff. And it's at the distal common, almost extending into the bulb, but more, the wire keeps going into the external carotid. Frank. Retrograde puncture of the internal?
Yes.
No, I'm just kidding. So we got a wire. I put it into the external.
Do you have a question for me?
Yeah. So wait, hold on. I put it into the external. And now, the wire, the wires, to be very honest, are not the ideal, first of all, to get that little bend in. And I really don't like to try catheters, to manipulate anything in that arch, in the bulb or even in the internal, because it's a symptomatic lesion. It's probably a very ulcerative lesion too. So I actually decided then to balloon that little string-like, band that goes right across the common, put the balloon only to the tip of the bifurcation, did not go into the external for fear that I may just jail the internal. So I ballooned it, and then I buddy wired the wire. Can you play that next one? And you can... No, show me the video, please. Play the next one with the wire, the recorded one.
No, the wire, the one you were playing.
That one, yeah. Just keep playing it. So I ballooned it. My wires in the external just ballooned the bulb a little bit and the distal common. And then I buddy wired it with a command wire. Now, the command wire is a long wire. The TCAR wire is a relatively short wire. I know Frank would be struggling with this, of course. I know he's better at golf, but I think we ultimately got it into the internal.
Looks like you're struggling a little bit.
There you go. See? And so we got it into the internal. Now, then the question is, of course, aggressive ballooning, and the debate is, of course, how aggressive are you in pre-dilatation? I'm pretty aggressive with pre-dilatation. I had ballooned this already with a 4 balloon to get a lumen to get into the internal, and then I used a 5.5 or a 6 balloon to do balloon angioplasty from the internal into the common. Show me the post-balloon angiogram. Yeah, freeze it. So this is the angiogram after ballooning, and it looks markedly better too. And so, I think an aggressive pre-balloon, and the patient tolerated it pretty well. He started off with, I do cerebral oximetry. He started with this pre-op oximetry of 62, and then immediately after ballooned it, it went up to 70. And then, of course, we then put in a stent. The question was to put in a short stent or a long. I always like to put in a longer 40 millimeter stent. It lines up nicely across the lesion. It has good proximal and distal distances so that we could post-dilate. And I try not to post-dilate as much as I can. And so, show me the angiogram. I was going to come live while deploying the stent and do it live, but I was so caught up with Dr. Sultan's presentation. And so that is it. So we took multiple angle views with and without wire. Go to the next one. And the patient's doing well. His SATs are now 75 and 74. And then we did that. So I think, it's a great result. You've done these TCAR cases in like 28 to 30 minutes. I do cerebral oximetry. We follow these patients. He's off reversal of flow right now. And then we take the en route sheath and then just close the purse string suture. Patient will remain on aspirin Plavix. So a couple of questions. One, pre-dilatation, post-dilatation. I think with the Contigo Performance 3, it's all filter, balloon, and stent. So I think we are post-dilating. And now whether that makes a defect or not in terms of the filter being there and reversal of flow. So post-dilatation, at least I try as much to avoid. Second, do you test patients for Plavix? Because recently we had a series of patients who are non-resistant, and I think Cassie Rajan can talk about that too, because at one time, it was a white label recommendation to actually test everybody for Plavix resistance. And so we had a couple of patients I had to switch to Brilinta. And of course, how long do you follow these patients and all the routine questions that come up when you do carotid stenting. So thank you guys. You all can continue the discussion, and I'm just going to take this out and I'll see you soon. Before I leave, we did have a case in the afternoon, but I think it's a fairly complicated thoracic case that may need even a single branch innominate. And so initially we debranched with the thought, but now they want to do an ascending debranching. And so we will not be doing a live case. And that actually fits in very nice with the program because we had quite a few presentations that were not done. And so we'll add them on to the schedule. And then I can come over there also and attend the meeting. So I want to thank the entire staff here at Osborne Hospital. We are doing cases actually in the cath lab because our hybrid OR is being remodeled and we're getting a new hybrid OR being built here. I also want to thank Egg Medical because we've done all of these cases with radiation protection. I had 98% protection for this case. Stephanie, the assistant, has almost a 94%, and everybody in the room, including the patient, is well protected. Even for these short procedures, it becomes a habit, a routine, and I think radiation protection is extremely important as well as doing the procedures without any discomfort of shelves and barriers and things like that. So thank you so much, and I'll see you soon, guys. Take care.
Venki, quick question.
Yes.
It's an incredible result, though. That was amazing technical skill. I think, many of us may have bailed in that situation. But the question I have is, you appear to still have flow reversal going.
No.
And there is some argument about, should you continue? Oh, you discontinued? Oh, I see. There's some question about how long should you continue flow reversal for? Sometimes some people believe run it at least for 2 minutes.
Yeah.
I tend to, if the patients can tolerate it, run it for 2 to 5 minutes, and I tend to collect more debris. So I'm curious as to your thought. We would also like to, if possible, to see what you collected in the filter if you're able to show it.
Yeah, I can take a picture of it once we take the whole thing out. But you're right. I run the flow reversal for at least a minute. And I don't know, it's a force of habit because when we used to do carotid stenting, we would aspirate through the sheath also. So even with flow reversal, I tend to aspirate also. And once, this may be anecdotal, at once with the aspiration in the syringe, I actually got particles. And so I not only continue the flow reversal, but I aspirate, pretty strongly, and then flow reversal for a minute after the procedure. And once in a while, I will actually shoot pictures after flow reversal just to make sure that the flow is good, especially in really bad, complicated, bad lesions and stuff like that. Yeah, but I think continuing flow reversal for a minute or two after the end of the procedure is very helpful. I'll take this out, and if we can get back to you, we'll show you the filter, see what's in the filter. Thanks, Cassie. Thank you, guys.
Thank you.
Take care.